Good afternoon, dear colleagues. My name is Wyngaert. I'm a nuclear medicine physician working at the University Hospital of Antwerp. So as you can see, unfortunately, I'm unable to join you today in person. There is still some 16,715 kilometers between us due to the corona pandemic, but I do hope, nevertheless, I will be able to get my message across to you. Of course, my gratitude to the organizing committee for inviting me to give this lecture to you today on the role of nuclear medicine in assessing the post-operative joint. As you can see, I've added the subtitle, The Case for Bone SPECT CT in Non-Infectious Complications. I will discuss briefly some facts about arthroplasty and the role of biomechanics and how that involves SPECT CT. And then, of course, we will move on to discussing some use cases in spine, hip, knee. I will not be talking about infectious complications because a prior and subsequent lecture to mine will address this topic in more detail. When it comes to imaging arthroplasty, we are all aware that we have not many choices, ranging from X-ray, CT, MRI to radionuclide imaging. And each of these modalities really has its own strengths and limitations. So X-ray is commonly available, however, it offers a low 3D resolution. MRI, in contrast, has very good soft tissue contrast, but it remains difficult to assess cortical bone, and there are issues with metal artifacts. CT offers very good 3D resolution and bone assessment, but there is difficulty in differentiating old from active changes. Radionuclide imaging using SPECT, on the other hand, has a very high sensitivity. There are fewer metal artifacts. However, there is low specificity. So when looking at these theoretical characteristics, it does seem that combining SPECT with CT makes sense, as it combines the strengths without any overlapping limitations. And while the introduction of SPECT CT has been a revolution in nuclear medicine, the technique itself has seen tremendous evolution over the last 20 years, starting from the slow rotation, low resolution X-ray tubes added to SPECT devices, along the way moving to fast rotation multi-slice CT, adding the capability of quantification, and more recently the introduction of new detector designs and ring geometry has really seen this modality mature to a state-of-the-art hybrid imaging technique that is fully suited for musculoskeletal imaging. So as a very brief introduction to the biomechanics of arthroplasty, we now have computational methods available that enable us to use musculoskeletal models of the skeleton, the tendons, and the muscles, combining them with finite element analysis of the bone itself, modeling the flexibility and the stress within the bone, and combining these with a thermodynamic model, because of course bone is a responsive tissue, so if it is loaded, it will result in bone formation. In contrast, when it is unloaded, it will result in bone resorption. So when combining these models, we can now predict the impact of, for instance, the insertion of hip arthroplasty, as illustrated on this slide, in the stress distribution and load distribution within the bone, and also predict where areas of micromotion can occur. And even though I am cutting many corners, you can see the resemblance of the simulated images with the findings that we have on bone SPECT CT. So taken together, there is a theoretical basis to explain the findings that we see on bone SPECT CT when it comes to bone remodeling and calculating or bringing it back to the changes induced by arthroplasty. And of course, this relationship makes bone SPECT CT a highly attractive imaging modality to assess the changes after arthroplasty. An example from the literature where a full finite element analysis was performed in patients with osteoarthritis and compared to the findings on fluoride PET-CT. And here it was shown that there was a strong correlation between the predicted areas of increased stress and indeed the areas visualized with increased bone turnover on fluoride PET-CT. Similarly, in patients with persistent patellofemoral pain, a finite element analysis was performed to predict the areas of increased stress between the patella and the femur, and this was correlated with the findings on sodium fluoride PET-CT, And again, it could be shown that the areas of increased bone turnover on PET-CT correspond to those areas with increased or peak subchondral bone stress as predicted using the finite element analysis. So how can we use bone SPECT-CT in the post-operative spine after fusion surgery? First of all, we need to have an idea of the reasons for revision, so the complications after these procedures. And in 1 out of 2 patients, that is due to mechanical complications, followed by spinal stenosis, disc degeneration, post-laminectomy syndrome, spondylolysis, and other reasons. When looking in the literature, there is data supporting the use of bone SPECT-CT to improve the sensitivity and specificity over CT alone after fusion surgery, that bone SPECT-CT changes the diagnosis in 45% of patients after spine fusion surgery compared to conventional imaging, and that this technique has a very high sensitivity and specificity to detect screw loosening and may therefore guide the decision for resurgery. This slide lists the different diagnoses that can be made with bone SPECT-CT in the postoperative spine. So facet joint arthropathy, spondylolysis and listhesis, disc and end plate degeneration, pedicle screw loosening or fracture, cage subsidence, pseudo-arthrosis, and of course referred pain, for example, from the sacroiliac joint. Again, I will not be mentioning spondylodiscitis. Of course, it is important to know what kind of a procedure has been performed, because one of the most common pitfalls, for example, is interpreting the elevated uptake around screw materials in posterior fusion. Why? Because 2 types of fusions can be performed. One of them is the rigid fusion, so solid rods are used, and this can be recognized on the CT component by seeing high dense material connecting the different screws. Of course, any elevated or diffuse uptake along the screws in such a construct would be suspicious for loosening, as it would indicate movement. On the other hand, in patients who receive a dynamic fusion where flexible rods are being used, as illustrated on the lower hand of this slide, where you can see that a low density material is in fact used to connect different screws. This is a different story altogether, because this is not a fixed construct. It is designed to be to allow some movement, and therefore increased uptake along the screws in these constructs is frequent, up to 10%, and it can even be transient due to the changes in the load bearing. So any uptake in such a construct would not be immediately suspicious for loosening. So when looking at SPECT-CT in the post-fusion spine, there are approximately 9 items on your checklist. So you will look for the vertebral body alignment to see if there's any malalignment or changes in this alignment occurring compared to post-operative imaging. You will look at the facet joint and the interarticular part, look for the preservation of the disc space or possibly the collapse of the construct, any changes in the end plate or changes in osteophytosis. You look for the integrity of the surgical hardware. You see if there is collapse and subsequent subsidence of cage material. Device position needs to be checked, and also look for clefts, lucencies, and bone resorption, which can be a sign of loosening. And finally, assess the bone formation, whether there is indeed bridging and cortication. I do not have the time to go too much into depth of all the different possibilities and diagnoses, but just to illustrate an important concept, adjacent segment degeneration. So basically, when one segment becomes fused, all the residual motion needs to go through the remaining segments, meaning that the stress per segment can actually increase, resulting in accelerated degeneration of these segments. So what you see here is the facet joint above a fused segment and the disc level below a fused segment, showing increased uptake on SPECT-CT due to adjacent segment degeneration. So again, the fusion itself is okay, but because the segment was fused, it has resulted in increased wear and tear of the joints above and below these segments. Pseudo-arthrosis is defined as a failure to produce solid fusion with continued motion in the segment, and the incidence varies between 5% to 56%, depending on comorbidities and other risk factors within the population. Unfortunately, it remains difficult to diagnose as there is no single imaging technique that can give you a definitive diagnosis. And bone SPECT in itself, we know, has a very high false positive rate, up to 1 out of 2 patients, so not really clinically useful. This has changed with the advent of bone SPECT CT, because we can now interpret both the findings of SPECT, which is high sensitivity, with CT, which offers better specificity. So again, if there is just some low moderate uptake and there is good signs of fusion on CT, you would not call this pseudo-arthrosis, but rather residual physiological bone turnover or micromotion. Only when there's high uptake on SPECT and you see inadequate fusion on CT is pseudo-arthrosis suspected. So an example on the left where you can see that there is a lack of bony bridging and there is asymmetrical intense residual tracer uptake in the fused segments. So this is suspicious of pseudo-arthrosis. Whereas on the right, you can see that there is just some residual uptake centrally located around the cages, where you would in fact also expect that bone integration is ongoing with good fusion on CT. So there is low probability of pseudo-arthrosis. Moving from the spine to the hip, we will do the same exercise. So what are the causes of revision surgery in hip arthroplasty? And here you can see that loosening is the number 1 indication in 1 out of 2 patients, followed by infection, instability, component failure, periprosthetic fracture, and then some other causes. So the evidence shows that bone SPECT CT is more sensitive to detect loosening and infection compared with SPECT alone, and that it changes the diagnosis in 16% of patients. SPECT CT identifies the cause of pain in 65% of patients after negative conventional imaging, and it changes the management in 68% of patients with unexplained painful hip arthroplasty. And interestingly, in 1 out of 3 of these patients, a non-hip pathology was diagnosed using SPECT CT. Another study showed that SPECT CT indeed identifies the cause of pain in 61% of patients. So this number is fairly constant throughout literature. Other authors have used semi-quantitative assessment of bone turnover and even more recently quantitative assessment, but those data are still too immature to derive any definitive conclusion. So similar to the spine, a brief list of all the diagnoses that we can make using bone SPECT CT. So we can look for loosening, periprosthetic fracture, heterotopic ossification, infection, avascular necrosis, tendinopathies, hyocytic reaction, polyethylene wear, and even referred pain, of course, this time coming from the spine. As I said, biomechanics are important, and we need to know the fixation zone of the femoral component in order to make a good assessment on whether there is loosening or not. Now, unfortunately, there are many hundreds, if not thousands, different designs of hip arthroplasties, and that does make it complicated. However, they can be reduced to more or less 7 types of arthroplasties, and these are shown on this slide. And what is basically important is the area marked in yellow, and this is in fact the part of the prosthesis that has been designed to integrate with bone. And that is important to know because that is the area which we will look at with most scrutiny to decide whether there is loosening. Shown an example of a short stem prosthesis, which is fairly popular in younger patients, where you can see that they are in fact very proximately fixating. And you can see a case in a patient where there is increased uptake not only in the distal part of the stem, which is the non-fixating part, but again, it is also present in the proximal part. So this would be an example that is suspicious for loosening. In contrast, a similar type of prosthesis in another patient where you can see that there is in fact only some uptake at the distal part of the femoral component. And as shown on the cartoon, this is not a crucial fixation zone of this type of prosthesis. So this is at first not suspicious for loosening. A similar strategy can be followed to assess the acetabular cups. So the crucial fixation zones are at the outer circumference. So that would mean that zones 1 and 3 are the crucial fixation zones. You should be where there is frequently increased uptake in the surrounding bone, but that is not at the bone prosthesis interface, so that is an important differentiator, and that osteolysis in zone 2 may in fact not be clinically relevant. So the criteria to speak of loosening is when there is in fact increased uptake at the prosthesis bone interface in more than one component, so zone 1 extending into zone 2 or zone 3 extending into zone 2, and when there is a corresponding CT radiolucency. An example of acetabular cup. So you can see here on the left an example of some increased uptake, which is not at the bone prosthesis interface, but in the bone adjacent to the acetabular cup. And on the right-hand side, where you can clearly see the pathologically increased uptake extending from zone 1 into zone 2. So this would indeed be suspicious for loosening. We suggested an imaging algorithm on how to use bone SPECT CT within patients with inconclusive first-line conventional radiography, where depending on where you think the issue is located, is it a prosthesis, is it the bone prosthesis interface, or is it more soft tissue oriented, and you can then use to decide what would be the most efficient or best imaging technique to use. Moving from the hip to the knee, we do the same thing. So why are knees operated after total knee arthroplasty? And here, unfortunately, you see that it's a completely different picture because it's all over the place. It ranges from infection, aseptic loosening, instability, malposition, approximately more or less in the same order of magnitude, followed by arthrofibrosis and less frequently patella femoral problems. So you really need to catch a much wider range of diagnosis in these patients. But nevertheless, literature data does support SPECT CT in this setting, with clinical benefit in 85% of patients with a painful total knee arthroplasty. Data showing that it is more sensitive compared to SPECT alone, that it changes the diagnosis and the final treatment in 85% of the knees, and that there indeed can be specific uptake patterns that can guide you towards the diagnosis in these patients. So the uptake patterns have been published previously, showing that posterior femoral uptake is suspicious for femoral loosening. That uptake below the tibial component and around the pegs and the stem is also suspicious. Some patterns for patellofemoral overloading I will show you in the following slides and link them to femoral internal malrotation or external malrotation. So an example of those tibial component loosening, you see increased uptake at the bone prosthesis interface in more than one compartments around the pegs of the tibial component. And for the femoral component, we are particularly looking for increased uptake in the posterior compartments. I've alluded previously on the importance of rotational alignment of the arthroplasty components, and this best illustrated using the case of excessive femoral internal rotation. So what you can see here is that causes a problem when you bend the knee, because it will cause the medial compartment to overload when you flex the knee, and this causes excessive wear of the lateral patellar facet and possibly subluxation of the patella. Now, these changes do cause a very specific pattern in bone SPECT CT, which can give it away. But of course, you can also measure some angles on CT, which can further support your diagnosis. So this is the pattern you will be looking for. So you see increased uptake on the lateral facet and on the medial femoral condyle. You can make these measurements yourself using some CT images. It is not difficult to identify the surgical transepicondylar axis, and also the posterior bicondylar axis can be easily recognized, and by measuring the angle between them, anything in excess of 6 to 8 degrees indeed would be too much internal rotation of the femoral component. So in this very brief overview of bone SPECT CT in the post-operative joint, I hope I have been able to convince you that SPECT CT is a major advance over planar and SPECT imaging alone in the post-operative joint, and that mounting evidence of important clinical impact in the management of patients with recurrent and persisting pain after joint procedures is available. And it is also linked to emerging understanding of the role of prosthesis biomechanics on uptake patterns and outcome. Of course, I do recognize that the literature is still maturing and further studies are of course required. In particular, data on cost effectiveness are still lacking. Nevertheless, patient selection is important and a careful consideration of the imaging techniques available is required. But I have presented you with some flow charts that I hope are helpful to you. If you're looking for more information, we did publish a nice series of reviews on the different joints a few years ago in Seminars of Nuclear Medicine, which include all of these flowcharts if you would be interested. So with that, I would like to thank you very much for your attention. I hope I have covered those areas of interest to you in your daily practice. Again, it's unfortunate we could not meet in person, but I do hope we will meet sometime in the near future. Thank you and bye-bye.